So it's a great pleasure to invite Professor Gordon Cook from Leeds in UK, a key leaders in the MRC studies that we all cited all the time and contribute so much to the field, and so well structured, like the MRC 10th and now the 14th study. And thanks for coming. And the topic is salvage autologous transplantation for relapsed multiple myeloma.
Thank you very much. I'd like to thank Mohammed and Thierry and Dr. Nagler for the kind invitation to come along to what is a fantastic meeting. And I look forward to coming back next year if I'm invited. This is my disclosures. And my task this morning, in a relatively short period of time, is to try and address the issue of salvage autologous transplant. So I'll look a little bit about the background, the main body of evidence, which we're pleased to know is primarily one study, and then just a little bit of looking towards the future. So since the seminal work of Tim McElwain and colleagues in London that showed high-dose alkylating agents had a role to play in disease control, and then the pioneering studies from groups such as the IFM to actually bring it into clinical practice, it's now standard of care and first line. But the role of stem cell transplantation in the salvage setting, defined here as the use of a transplant after progressive disease from a prior transplant, is relatively uncharted territory. There is somewhere in the region of about 21 publications of retrospective single-centre evidence and experience, but until the publication of the study I'm going to show you, there was no prospective evidence about its utility in this period. So some 10 years ago, I penned the idea of a randomized controlled trial to test the clinical utility of a salvage transplant in patients who have relapsed after a prior autograft. And we published our primary endpoints in the Lancet Oncology 3 years ago now. But for those unfamiliar with the study, this is the schema. For patients who had at least 18 months freedom from disease progression from the prior transplant, were re-induced by a bortezomib-containing regimen, Jamie Kavanagh's PAD regimen. We also wanted to test whether it's possible to remobilize stem cells after a prior transplant. And then patients were randomized to receive a second transplant, standard dosing of melphalan versus a non-transplant consolidation, which at the time when I penned the idea, low-dose cyclophosphamide over 12 weeks was what we chose to go with, a regimen which is used in the UK for patients who are not fit to go forward with the transplant. This is a study cohort, so they're actually balanced between both arms. And the first thing you'll notice is that the trial recruitment was aimed at over 400 patients, and yet we, in the end, published on 297. And that's because a pre-planned interim analysis indicated we had reached our primary endpoint, so we stopped the study at that stage. Second thing I'd like to mention is that almost 3/4 of the patients who went into this study had at least 24 months freedom from disease progression from their prior autograft. And this is quite relevant when we look at the genetic landscape at relapse. And this is just a snapshot, but more detailed publication on this will be forthcoming. But in actual fact, in this group of patients who you could define as being good risk because they had at least 24 months freedom from disease progression from a prior transplant, only about 1 in 3 of them had no detectable genetic abnormality by FISH. And in particular, there is a group of people who have got ultra-high-risk disease, as we define in the UK as having more than one genetic abnormality. I think one of the things that surprised me most was the level of MYC rearrangements we saw in this group of individuals. Just to answer the question about can you remobilize peripheral blood stem cells after a prior autograft, we published this in BBMT now just about a year ago, and effectively the remobilization efficiency was 52%. Now the majority of these remobilized patients were actually using cyclophosphamide G-CSF, because the time we ran this study, access to plerixafor was somewhat limited in the UK, and very few patients got plerixafor. I'm sure that the efficiency of remobilization would be improved nowadays because of the free access to plerixafor we have in the UK. In terms of response, this is the depth of response. As you can see, to the re-induction, we had a stringent CR rate of just under 17% that rose to just under 40% in the transplant arm compared to just over 20% in the non-transplant arm. And the primary endpoint was time to progression and PFS, which is similar in this study. And basically what you see on this Kaplan-Meier plot here is the superiority of the patients who underwent the salvage transplant compared to the non-transplant consolidation. And this is with a median follow-up of 52 months now on the updated plot you can see before you. And when we looked at the predetermined subgroup analysis, then as you can see, most groups get a benefit from that second transplant, with the exception of our high-risk disease patients here, which in actual fact, although not statistically significant, was suggesting that in fact they were better off not having a transplant in this setting. And that's clearly setting out a stall for an unmet need in this setting. So when we looked at our secondary endpoints, which was depth of response including MRD and overall survivorship, and we published this last summer, one of the things to note here is the treatment-free interval between both arms. And the blue line represents the transplant arm, and the red line here represents the non-transplant arm. And what you see is a significant difference in treatment-free intervals between these two interventions. And that's something that's very important for patients to get on with their life, to improve their quality of life. First question we had was, did having a second transplant compromise your subsequent treatment duration? And we used for that as a measure of PFS2. Over 80% of patients who relapsed off the trial protocol were treated with a lenalidomide-based regimen. 25% of patients in the non-transplant group from the trial actually received an autograft in third line. Only one patient in each arm received an allograft. And as you can see here, the PFS2 was actually maintained in the autograft arm compared to the non-transplant arm here. But what happens if you have a second transplant in third line? Do you get catch-up? Well, according to our data, no, you don't. You're still better off to have that salvage transplant in second line rather than delaying it to third line. In terms of overall survival, then, in fact, the trial showed that patients who had a salvage transplant had a median overall survival of 67 months compared to 52 if they did not have a transplant. And again, when you look at those who had the original transplant, 4-year overall survival is 69%. But if you actually had the catch-up transplant, then there's a non-significant difference in the survivorship of 61% at 4 years. Minimum residual disease. Now, this is using multi-parameter flow cytometry and they're using a central lab to run this, and the sensitivity of that assay is down to 10 to the minus 5. And it's fully very nicely showed this morning, and Dr. Munshi showed yesterday, the MRD is largely treatment agnostic. So as you can see here, the blue line represents patients who are MRD negative versus MRD positive, and this is PFS, but the curves are actually very similar for OS as well. But of course the difference is your intervention increases the quantity of patients who get MRD negativity. So post-induction we had 1 in 4 patients getting MRD negative, which almost doubled with the transplant compared to increasing only to 36% after the non-transplant intervention. And I think that's the relevance going forward. Now, this is a bit of a post-trial analysis, so please take this with a very large pinch of salt, because the trial was never set out to answer this question and therefore was not powered. But basically I asked the question, what is the difference between treating biochemical versus symptomatic relapse? And just to kind of focus your attention, this is the TTP and the OS here. The red line are patients who had biochemical relapse and then went on and had randomized to receive a salvage transplant, suggesting that in actual fact that intervention gives you a benefit if you go early. But I say, please take this as the caveat that the trial was not powered to answer this question. I think it raises a number of questions that we might want to concentrate on going forward in a novel trial design. So what has this work meant? Sergio Girault made a fantastic job of bringing together a group of us to talk about transplantation. And this was collaborative work between the American Transplant Society and INWG, and published in BBMT just start of last year, I think, from memory. And basically incorporated in that, and it was already mentioned by Dr. Nagler this morning about allografting. Well, salvage autografting is very firmly in the recommendations of this manuscript. So when we get down into the real world, is this being adopted? And this is the UK transplant activity, which I was the custodian of until just the start of this year. And what you can see is that the blue columns are first autographs and the red columns are second autographs. And as you can see, the level of second autographed activity is steadily rising as the autographed activity overall continues to rise. And what I've done here is just proportionality illustrate that as we go forward, the proportion of all the autographs being done in the UK is increasing as second transplants going forward as a consequence of the data that I've just shown you. So then the question is, of course, well, if two are good for you, surely you're going to get a kick from a third one. Perhaps not. This is, again, BSBMT. This is outcome data that I, as the president of the Transplant Society, had to produce to satisfy our politicians. And this is one of the things it showed, and what we found here was that the median PFS from people who had a third or a fourth autograft was actually only 8 months, and the overall survival was less than 1.5 years. And therefore that is not a commissioned or reimbursed activity within the UK. But there's a relatively small group of patients who received a third or fourth autograft. So I'm very grateful to a friend and colleague of mine, Laurent, who undertook an in-depth study on behalf of the myeloma subgroup of the Chronic Leukemia Working Party of EBMT. And Laurent presented this at ASH last year, and the manuscript's very much in preparation. And he looked at the third autograft. Of course, there are two definitions of a third autograft. There are people who got a tandem up front, relapsed, and then got a salvage autograft, which is represented in the blue bars here, versus those who had an auto, relapse, salvage auto, relapse, and then had a third one, which are represented by the green line. And as you can see, that the blue line pretty much performs along the similar lines to the data I showed you from our prospective study of salvage autograft, and that those who have a genuine third line third autograft, that their outcomes are significantly poorer than if you have it as just a second line intervention. But of course, one of the problems with such analyses is trying to, particularly looking at this group here, that Laurent only had 72 patients to play with. But one question is, what about the patient who had 5 years plus from their first autograft and had 5 years plus from their second autograft? How are they going to fare with a third autograft? And I think it's very difficult to answer that question because the data is not there. Again, food for thought in this context. Unfortunately, Paul's disappeared because I put this specifically in for Paul's amusement. I do like to show some Donald Trump images for him. But anyway, where are we going with this in the future? And as Dr. Nagler has already mentioned, closure of Myeloma 10, the United Kingdom Myeloma Research Alliance, or MRA, is moving forward with Myeloma 12. And this opened just this month. And basically, same recruitment criteria, relapse after a prior autograft with at least 18 months PFS, and people are going to be re-induced with ixazomib, thalidomide, and dexamethasone. So the questions I want to answer with this study is, can we improve, because I've got data that the durability of a salvage transplant is less than a first-line transplant, so can we improve the depth of response and the durability of response by augmenting that transplant? And here we're going to use IMEL. I realised that to be trendy, all you need to do is have a lowercase I in front of whatever you're trying to do, and everybody thinks that's state-of-the-art. But what we're going to do is use ixazomib to augment high-dose melphalan, and I'll show you the schedule in a minute. And the second issue we're going to look at is, what is the role of post-transplant consolidation and maintenance? We all know about its role in first line, but there is absolutely no data whatsoever in the salvage setting, and therefore it's legitimate to randomise between no interventions and consolidation maintenance going forward. This will be the IMEL schedule. 4 milligrams, D minus 4, 4 milligrams, D minus 1, and melphalan split is 100 over D minus 3 and D minus 2, and then transplant as usual, unmanipulated graft on day 0. And the primary objective is looking at the depth of response from the first randomization of the augmented versus standard transplant. We will have MRD detection, again, single lab, multi-parameter flow cytometry and NGS within this study. And then randomized to the primary objective will actually be PFS. So, what I've tried to do in the last 10, 15 minutes or so is actually give you the only prospective data that exists in this setting for the use and utility of a salvage autograft. But as Paul's already mentioned this morning, the landscape is becoming increasingly busier, and therefore how will this feature going forward? And I'd like to think that the transplant has a role with novel agents rather than instead of novel agents and vice versa. And I think that's something we need to investigate going forward. As per all such talks, this is a team effort, and this is the MRA Myeloma 10 team, which are very similar to the Myeloma 12 team going forward, with the exception of my friend and mentor, Cully Morris, who has actually stepped down from the front line trial management and is actually going to be involved in chairing my trial governance committee to make sure I behave myself going forward. And then with that, I'd like to thank you very much for your attention and happy to take any questions. Thank you.
So, thank you for a very important and elegant talk.